Good afternoon. I would like to welcome my colleagues from Utopia General Hospital to today's presentation on care coordination and the different factors which affect our ability as nurses to effectively coordinate patient care. My name is Bobbie Bohack, and I am pleased to be speaking with you today as part of this project for NURS-FPX4050, Coordinating Patient-Centered Care, led by Dr. Mims. Let me begin by explaining a bit about care coordination. The Agency for Healthcare Research and Quality defines care coordination as the, quote, efforts taken to see that information is shared among everyone who participates on a patient's care team so that their care activities are organized with the goal of creating safer, more effective care, end quote. Taken from the ahrq.org website published in 2018. Essentially, care coordination is making a concerted effort to meet all of a patient's needs by communicating among the team in a way that guides the care being delivered. An effort also needs to be made to involve the patient and support their goals for self-management while linking them to resources from their community, as appropriate, that align with their goals and needs. This collaboration of patient and providers to coordinate care has been, according to the AHRQ website, identified by the Institute of Medicine as a concept that can improve the safety and efficiency of the healthcare system while additionally improving the outcomes both patients and providers experience. According to a 2018 piece published by the New England Journal of Medicine Catalyst, there are 4 elements that are needed when acting to coordinate patient care. First, access to healthcare should be easy to come by no matter what provider a patient is seeking out or service they need from that provider. Second, communication and transitions between various healthcare providers need to be effective for the patient. Third, focus should be placed on the overall healthcare needs that the patient has, with an effort to see the bigger picture as the goal for each member of the patient's care team. Finally, the 4th element is providing clear, easy-to-comprehend education and informational resources for the patient so that they may better understand what is expected and anticipated throughout the course of their healthcare journey. These elements combined describe a complete and effective way to encourage collaboration by all parties involved that will naturally lead to the care coordination that the AHRQ defines as necessary to improve outcomes. You may be wondering, when exactly is coordinating care warranted? The simple answer is always. According to the New England Journal of Medicine Catalyst article from 2018, care can be coordinated during primary, acute, and long-term interactions with patients. The article describes a guided care model that was developed by a research team at Johns Hopkins University where, as a nurse performs their initial assessment, they are also working with the patient's primary care providers to develop the patient's care plan, and including specialty providers to make sure that they include all of the details of a patient's plan of care. This guided care has been shown to, quote, decrease total healthcare costs by 11% with an average net annual savings of $1,364 per patient, end quote, as well as achieve a reduction in hospital readmissions. As registered nurses, you have the ability to follow these simple steps of inclusion and collaboration among the care team to help reach these same goals. Now that we have covered coordinating care from a primary provider's perspective, let us look at the concept of acute care coordination specifically, which can be more complex to coordinate. If a patient presents to the emergency department at midnight on a weekend, the odds that they will even be able to reach their primary care provider are not in their favor. This leaves room, as the article by the New England Journal of Medicine Catalyst describes, for, quote, communication breakdowns, redundancies, and medical errors, making it even more important that healthcare be synchronized and coordinated to achieve the best clinical results, end quote. Coordinating this level of care means working to be sure that once the patient is through the initial acute phase and moving on to being discharged from the hospital, that transitions are coordinated, such as ensuring medication prescriptions are filled and follow-up instructions are provided. Working to see this through helps to reduce readmission and mortality rates, according to the New England Journal of Medicine Catalyst 2018 piece. You can see no matter where you work in healthcare or what patient population you deal with daily, there are opportunities to improve their healthcare outcomes by acting as an advocate and working as a team to coordinate the care they are given. The next question is, how do we make the most of our efforts? To avoid wasting time and resources, it is best to find strategies to employ during one's care coordination efforts that will optimize the collaboration between patient, provider, and everyone else involved as part of the care team. There are 3 models for care, which I would like to speak to you about now: the patient-centered model, the transitional care model, and interprofessional rounding. Each model for the provision of care offers slightly different strategies to utilize during collaboration efforts. By combining these 3, it would be possible to achieve a more comprehensive and effective care plan for our patients. Here at Utopia General, we currently focus on providing care following the patient-centered model, as that is mentioned in the article by Shirey in 2017. While this strategy focuses on the patient and their needs, it leaves open the chance that their transitional care or providers they see outside of the setting will be overlooked. The Shirey article describes how, by combining the transitional care model and patient-centered care model, a combination which can address the need of the vulnerable population we serve, can better see their needs. With an emphasis of coordinating care across transitions, such as being discharged from our facility to a skilled nursing facility, we can address any barriers to care and facilitate a more complete transition. For example, if a patient is given discharge instructions that include specific exercises recommended by physical therapy, but no one at the nursing facility they are transitioning to is aware of this, there stands a chance that the patient may forget to perform these exercises, or that their PT team there at that facility will not be aware of what has already been accomplished. The simple act of paying attention to the transition period and including appropriate handoff reports and follow-up can increase the level of coordination we practice, thus increasing the level of care the patients receive. This brings us to our next model of care, interprofessional rounding. While including the interprofessional members of a patient's team during the transition is important, we should also remember to be inclusive during rounds of all branches of a patient's care team here. The Shirey article from 2017 describes how formal, interprofessional rounds can facilitate more effective communication and improve safety and quality of care. We currently do not have a system of interprofessional rounds set in place here at our facility, but instead I encourage you to reach out to the staff you see rounding. When therapy or physicians are making rounds, take a moment to approach them while they are bedside. Politely express any concerns you have for those patients or inquire to see if there are plans or suggestions that your awareness can assist with. We do hope eventually to have a more formal process in place for interprofessional rounding here in our facility, but until then, practice the efforts of including and being included when you can. As nurses, this is one very effective way to collaborate with the rest of your patient's care team efficiently. By actively engaging other staff members when they are available and rounding, we can all work towards more effective collaborations with those same team members and patients. Now that we have discussed the concept of care coordination and some of the strategies we can use to create more effective collaboration, let's look more closely at a policy that has some influence over why we want to provide the most comprehensive care possible. The Hospital Readmissions Reduction Program, or HRRP, is one piece of the Affordable Care Act of 2010 that some of us here may or may not be familiar with. Essentially, the HRRP enforces financial penalties on facilities whose 30-day readmission rates for specific conditions are too high, taken from Chen and Grabowski in 2017. These conditions are acute myocardial infarction, pneumonia, heart failure, COPD, hip replacements, and knee replacements. Pause and think for just a moment about what all these conditions have in common. They all require extensive follow-up and coordination from a team of care providers for the patients to remain as healthy as possible, given the circumstances, and prevent them from returning to the hospital in worse condition than they arrived the first time, don't they? The financial penalties imposed upon the facility can barely touch the sincere misery that a patient must feel when they must be readmitted. The Chen and Grabowski article details how, in 2011, $24 billion was paid by the U.S. Medicare program in costs for readmissions with these targeted conditions. But what did those patients pay in time away from home or pain? We all acknowledge that there are some costs that we cannot attach a dollar amount to. As the Chen and Grabowski article describes, it, quote, Medicare's goal in implementing the HRRP was to encourage hospitals to reduce 30-day readmissions through better hospital care, end quote. In a very simple and direct concept, I would bet that any one of us in this room can think of at least one patient we know who we see frequently, has one of those conditions listed, and I would hazard a bet that we have never stopped to ask ourselves, what we could do differently to coordinate care, such that said patient stays well in home this time. Jokes are often made about frequent flyers, but perhaps we need to be asking ourselves how to avoid them taking flight. The HRRP gives a financial reason to avoid readmissions, and concepts such as care coordination and collaboration give us tools to improve the care we provide so that we can reach a goal of reduced readmissions. The next important piece in this game we call nursing is, believe it or not, how we go about making the decisions and choices we need to in order to support our patients. Behaving ethically, acting in the best interest of your patients and their families. This is a decision-making process that can be learned over time. Many nursing schools teach the fundamentals of ethical decision-making, that is, according to the Gibbons and Jeschke article written in 2016, how to go about encouraging the health of your patients by developing therapeutic bonds with them, which will help you advocate on their behalf and guide them appropriately as they make decisions about their health care. As a nurse, your character shines through, much as the article by Gibbons and Jeschke states, every time you offer your patients care in a humble, honest, and compassionate manner. Sometimes this means you will need to advocate on their behalf to get them more than they are currently receiving. Perhaps they need physical therapy and they aren't scheduled for it, so you work to get them on the list. Sometimes they desire less. These can be the hardest times, the ones that test your own ethics and morals. Perhaps their medical team feels that a specific treatment will prolong their life, but they are ready for hospice or palliative care. The most appropriate and ethical thing in this case is to advocate for their wishes, but it is not always the easiest thing, especially when you have spent enough time with the patient to form a bond with them. Remember, as nurses, your individual views on what is ethical and correct may sometimes guide your behaviors, and sometimes you will need to set aside your views and beliefs to support your patients. Always act in the best interest of your patient, even when it may be challenging to step up for them. Ultimately, as much as the Gibbons and Jeschke article writes about, quote, it is up to practicing nurses to be advocates for patients, families, and healthcare teams, end quote. An editorial piece written in 2020 makes note of the fact that, quote, one of the major criticisms of our current healthcare system is that it is too focused on providing episodic care, end quote. Patients are treating during the acute phase of their illness, stabilized, and then, often dependent on their insurance status, are sent home without the proper follow-up being done. This leads to our patients with chronic conditions, who often only present to us when something more severe occurs here at the hospital, being affected by more serious complications over time. It also, as the article from 2020 points out, leads to insurance companies spending higher amounts on emergency interventions than they would on supportive care that promotes wellness. So how do nurses fit into this? How do we work to achieve a continuum of care which spans a patient's lifetime and not just a snapshot in time? First, we must define what we mean by continuum of care. There should be, according to the article from the Sentinel, community-based services available, disease management programs for those with a chronic condition such as diabetes, health information systems which are integrated to make transitions easy and seamless between providers, and case management services available to assist with coordination of healthcare efforts. As you can see, we have already discussed several of these today. Our community has many services, which not all of our patients or even staff members are always aware of, which we can offer to our patients, including programs to help manage chronic illnesses. Utopia General has several nurse informaticists on staff who are working to improve the design and functionality of our electronic record system. There are also case managers on staff. Some of you may have even seen the recent opening we have for a case manager position and thought about applying. None of these mechanisms are foreign concepts, but working to better integrate them is needed if we want to see improved outcomes for the patients we serve. Second, ask yourself what steps you can take in your daily interactions with your patients to improve the continuum of care. We've discussed several actionable steps that can be done to improve the care patients receive today. Actively engaging in rounds with other practitioners, involving the case managers as needed, and even just offering simple informational pamphlets on the community resources that are nearby Utopia General when a patient is unsure of what other options they have to continue to promote their health and wellness are just a few of the things you can do to improve the continuation of their care beyond the acute phase when they are here at Utopia General. One final point we will discuss today is change. There is a growing and changing community here, and Utopia General needs to keep pace with these changes and the growth the community is experiencing to continue serving the needs of the community. Without change, this cannot occur. What model will we follow as an organization to work to bring about the changes needed to enhance the experience of our patients? Here at Utopia General, we will begin by following Kurt Lewin's change model, which many of the nurses present today may remember from nursing school. The 3 phases, as described in a 2016 article by Hussein et al., are unfreezing, or discontinuing the current ways which are not working, the change process itself, where new methods and concepts are put into effect, and refreezing, so that the new methods become positive habits. Another valuable point made in the article by Hussein et al. Is that the employees here will need to be involved during this change to make it effective. Speak up, share your concerns or helpful ideas that you may have, and by being proactive in implementing these changes or altering things which are not working to find a better way. As the facility works to unfreeze from the old ways of focusing primarily on the acute presentation and changes to be more inclusive of promoting the continuum of care, the management and teams here at Utopia General are prepared to listen and support the nursing staff through these changes. We hope to see our efforts refreezing into a more coordinated and collaborative effort, which enhances the care of our patients receive and continues once they leave the facility. I would like to thank everyone for coming today, being present, and making the effort to learn how we can improve the coordination of care offered by the staff here at Utopia General. Hopefully, there are at least a few points that everyone can take with them from here and begin to work on. The potential for growth and powerful, effective change exists in each one of you, and we here at Utopia General look forward to seeing this take place as we move into a new phase of our own growth as a facility. Again, thank you for your time. If anyone has any questions, I would be happy to answer them.